So continuing with respiratory emergencies, this phase of the chapter will focus on patient assessment, specifically for respiratory emergency patients. So scene size up, start with your scene safety, use standard precautions and PPE, consider possibility of infectious disease or toxic substance. If necessary, consider the MOI. It might not be necessary, but definitely consider the nature of illness. If in question, ask why 911 was activated. So if you're not sure if a MOI is present or a nature of illness is present, ask why 911 was activated. Question the patient, family, or bystanders to determine the NOI. Once you have completed your scene size up, so ensure that your scene is safe, take the necessary standard precautions for you and your partner. Identify the nature of illness, consider how many patients you have, whether or not you need additional resources. After you've performed your scene size up, next phase is your primary assessment. And the goal is to identify immediate and potential life threats and address them. So identify immediate life threats, form a general impression of the patient and the environment. Note the age, does need to be the specific age, the developmental age group, and the position of the patient. Use your AVPU scale. Ask the patient about the chief complaint. Based on the patient response, you'll be able to ascertain the airway, assess the airway, and assess breathing. Make sure the airway is patent and adequate. Assess rate, rhythm, quality, and depth of breathing, because we want to identify issues with ventilation, oxygenation, or respiration. Ask the following questions, or consider the following questions. Is air going in? Does the chest rise and fall with each breath? Is the rate adequate for the patient's age? Assess breath sounds. Very, very important. So check breath sounds on the right and left sides of the chest. Abnormal sounds include wheezing. Wheezing indicates bronchoconstriction. Rales and rhonchi indicate fluid in the alveoli, and stridor indicates an upper airway issue. Very important for you to listen to lung sounds if you suspect that the patient has a respiratory problem. Now, based on your findings for upper airway and breathing, you will manage accordingly. For circulation, assess pulse, rate, rhythm, and quality, or rate, rhythm, and strength. Evaluate for shock and bleeding. Assess perfusion by evaluating skin color, temperature, and condition. After you have completed your ABCs and you have addressed your life threats, you should know at this point what is your patient's GCS. Now is a good time to check your pupils as well. So what is a patient's GCS? You can check the pupils at this point. Do you need to do a rapid scan or a focus? And for your medical patients, the rapid scan is going to be necessary if the patient or bystanders or family members cannot tell you clearly what the issue is. Rapid scan is going to be required. If the patient can tell you specifically what is happening, focus on the system that is being affected, which would be the respiratory system. So again, after your ABCs, what is the patient's GCS? Can check pupils at that point if you want. Is this patient going to require a rapid scan or a focus? Is this patient a load and go patient or a stay and play? These questions must be answered. Transport decision. If the condition is unstable, there is possibly a life threat present. So address the life threat, proceed with rapid transport. Now, once we package the patient and we're getting ready to transport the patient, if that patient is communicating with you, ask questions. So questions, vital signs. If they can't communicate, think about your physical findings. What is the vital signs? Who else can give you information about the history? And in your vitals, it's going to include pupil reaction, pulse oximetry, blood sugar reading. Now, in your history taking phase, investigate the chief complaint, find out what the patient has done for the breathing problem, sample history. And in your signs and symptoms, you will tie your OPQRST to your signs and symptoms. The purpose of a OPQRST is to find out information about the presenting problem. So OPQRST assessment: onset, provocation, palliation, quality, radiation, or region severity. Your paced assessment can also be utilized. So progression associated with chest pain, sputum, talking, tiredness, exercise tolerance. Start to get comfortable with these abbreviations or acronyms. Now, once you have completed your history taking phase, the next phase is your secondary assessment. So in your secondary, you're either going to be doing a detailed head to toe or a focused systematic assessment, and you're going to be collecting your recorded vital signs. So the secondary assessment is more in-depth assessment of the body systems. Proceed only after addressing live threats. Use monitoring devices if you have them. Your pulse oximetry, end-tidal CO2, cardiac monitor. Look for signs of COPD. Patient older than 50 years of age, history of lung problems, active or former cigarette smoker, tightness in the chest, constant fatigue, barrel-like appearance to the chest, use of accessory muscles, abnormal breath sounds. After your secondary assessment phase, the next phase is your reassessment. Right? Now, remember, when we're doing vital signs in our secondary, it cannot be that this is your first initial checks. Right? So when you're doing vital signs in your secondary assessment, it is to compare to your primary assessment findings, whether or not you have given treatment. So whether you gave treatment in your primary or not, the vital signs that you do in your secondary assessment, the purpose of those vitals is to compare to your primary findings. You want to know which trend is occurring. Is the patient trending up or trending down? Very important. Or is the patient stable? In your reassessment, you're going to repeat your primary assessment. Assess for changes in the condition. Your interventions may include oxygen via non-rebreather mask at 15 liters per minute. It can include positive pressure ventilations, which can be assisted, it can be artificial, or it can be CPAP. Airway management techniques may be required. Positioning in a high Fowler's position or position of choice may be necessary. Most patients with respiratory problems tend to sit and lean forward. Assisting with respiratory medication, once it's within your protocol, may be necessary. So you, as an EMT, you're allowed to administer Ventolin for bronchoconstriction. So you can nebulize a patient with Ventolin. That's within EMT protocols. Now, emergency care. Administer supplemental oxygen. Some patients may need CPAP or bag mask device. Patient may have meter dose inhaler or small volume nebulizer. You can assist them with administration. Consult medical control and make sure the medication is indicated. Ensure there are no contraindications. Most medications are used to relax the muscles that surround the air passages in the lungs. Common side effects of inhalers, because they are sympathomimetic in nature, they will mimic the sympathetic system, so it's going to cause increased pulse rate, nervousness, muscle tremors, blood pressure can go up. When you're assisting with a meter dose inhaler, it is 2 puffs, so it's 1 puffs, and then 5 minutes time, another puff. Don't give them the 2 puffs one time. Treatments for specific conditions. For upper or lower airway infection, remember your humidified oxygen, right? So once it's available, get them on the humidified oxygen. Do not attempt to suction the airway or place an oropharyngeal airway unless it is absolutely necessary. Position comfortably, transport promptly. For acute pulmonary edema, 100% oxygen, be prepared to suction, position comfortably, provide CPAP. So CPAP is one of the gold standard for removing fluid from the alveoli. So especially for your CHF patients, right? So remember that. Transport promptly. For chronic obstructive pulmonary disease, assist with prescribed inhaler, watch for side effects from overuse, position comfortably, transport promptly. For your asthma patient, be prepared to suction. The asthmatic patient may have a rescue inhaler. You can assist them with that. Your protocol may allow you to nebulize with Ventolin. You can do that. Provide aggressive airway management, oxygen, and prompt transport. And in the hospital, you might see the nurses sometimes nebulize with saline. Basically, they're trying to loosen up the secretions. And when you give the patient humidified oxygen, it basically kind of do the same thing that nebulizing with saline would do in terms of loosen up secretions. For hay fever, these patients really will need any emergency treatment. Usually antihistamine is fine for these patients. Anaphylaxis, life-threatening condition. So remove the offending agent, maintain their airway, transport rapidly. First line treatment is epinephrine, but if they need oxygen, give oxygen, then get your epi ready. Bottom end treatment is going to be antihistamine, DPH. But you never give an anaphylactic patient DPH first. That's not going to solve the problem. Treatment of specific conditions, spontaneous pneumothorax. Provide supplemental oxygen. You need to monitor lung sounds. So you need to monitor this patient's lung sounds. They are at risk for developing obstructive shock as a result of a tension. So you need to monitor the patient's lung sounds and look out for signs and symptoms of a tension pneumothorax. So for pleural effusion, fluid removal must be done in the hospital. We can't do anything about that in the field. Provide oxygen, prompt transport or transport promptly. For obstruction of the airway, if it's partial obstruction with good air exchange, monitor the patient. You don't have to do anything if they have good air exchange. If it is partial obstruction with poor air exchange, then you need to do something about it. Provide supplemental oxygen as needed and transport. For complete obstruction, clear obstruction, and administer oxygen, transport rapidly to emergency department. For pulmonary embolism, supplemental oxygen is mandatory. Position of comfort. If hemoptysis is present, you're gonna have to clear the airway immediately as needed and transport promptly. Remember, they will have cyanosis and you might not see any changes even after you have given oxygen because there is a block in the pulmonary artery. For your patient with a panic attack, complete primary assessment and get a history. History is important. Do not have the patient breathe into a paper bag. If you need to give them oxygen, use a partial rebreather where they can get rid of the CO2 and they're getting oxygen at the same time. Do not immediately put the device on the patient's face. Make an attempt to calm them down. It can work, it cannot. Don't freak out. So if it don't work, don't freak out. Eventually the patient is going to lose consciousness if they're not following your instructions. When they do what you need to do and monitor their airway. Do not freak out. Transport promptly. For environmental and industrial exposure, ensure patients are decontaminated. Treat with oxygen, adjuncts, and suction based on the patient presentation. For foreign body airway aspiration, clear the airway, provide oxygen and transport. For tracheostomy dysfunction, position comfortably, suction to clear the obstruction, and if you're going to be suctioning a tracheostomy, it must be a sterile technique. Provide oxygen. For your asthma, provide blow-by oxygen, and blow-by oxygen in this instance would be more for your infant or newborns. We don't put the oxygen device directly on their face. For your older pediatric patients and your adults, you can put a supplemental device on their face. Use the MDI if they have one. Now, most units in the current EMS response don't really carry MDIs anymore. They're gonna have small volume nebulizers. And as I said previously, it is within your protocol as an EMT to nebulize the patient if it is indicated. Cystic fibrosis is a condition that produces excessive mucus within the body. And one of the places that it can cause problems is in the lungs. Treatment will center around suctioning and providing oxygen as needed. And I believe that would bring us to the end of this chapter.